Continuing on with heart failure, we also use cardiac glycosides. So cardiac glycosides, this is the tetracycline of this lecture, meaning you need to know all about cardiac glycosides. So read about this in your textbook, read about this in your ATI book. You cannot read enough information about cardiac glycosides. There are about 50 questions that I could answer, that I could ask you right here and now about cardiac glycosides. It's quite common. So we're talking about digoxin, goes under the brand name Lanoxin. And the purpose is to increase the force of the heartbeat, slow the heart rate. The primary problems associated with heart failure is decreased contractility, and digoxin increases that contractility with the whole purpose of treating and improving the cardiac output. It's currently second-line therapy for heart failure. It was once a mainstay, but now we have newer drugs that are working. It has a very narrow therapeutic range, with the optimal therapeutic level being between 0.5 and 0.8 nanograms per ml. We have to worry about digoxin toxicity, and we see confusion, irregular pulse, bradycardia, EKG changes such as VTAC, VFib. We may see some sinus atrial blocks, some AV blocks, loss of appetite, nausea, vomiting, diarrhea. Note, not constipation. We see diarrhea with digoxin toxicity. We could also see palpitations and all sorts of visual disturbances, such as yellow halos around light. Sometimes everything looks a little green, blind spots, seeing spots, snowy vision, photophobia. These are all visual disturbances that we see. So if you see a question and it talks about some sort of visual disturbances, automatically in your mind, part of your differential answering should be digoxin toxicity. We also see decreased urine output, difficulty breathing when laying down, excessive nighttime urination. So we see hypokalemia with digoxin, so we want to make sure these patients are having an adequate intake of potassium. We see dehydration, a decrease in magnesium, and all sorts of drugs interact with digoxin. Your role as a nurse is to know the signs and symptoms of toxicity, ding, ding. Monitor the therapeutic levels. Evaluate for ventricular dysrhythmias. Remember, ventricular dysrhythmias are really bad. VFib, VTAC, you need to initiate ACLS. Digoxin has a monitoring parameter. So for an adult, it's 60 beats per minute. So if adult's pulse was 59, we would not give the dose. We'd hold the medication, call a provider. 70 beats per minute in children and less than 90 beats per minute in infants. Ding, ding. Report any weight gain. That would be worsening congestive heart failure. We are not expecting that with good treatment. These patients need to eat foods high in potassium, and monitor for signs and symptoms of hypokalemia, such as nausea, vomiting, generalized weakness, which is very similar to that of dig toxicity. Remember, we want to keep the potassium level between 3.5 and 5.0 milliequivalents per liter. We're moving on to beta blockers. We've already talked about beta blockers in our hypertension. These slow the rate of the heart and reduce blood pressure. They decrease the workload of the heart, such as metoprolol. Remember, this is a cardioselective. It blocks the cardiac action of the sympathetic nervous system to slow the heart rate and reduce blood pressure, thus reducing the workload of the heart. Remember, we have a pulse parameter of 50 with our beta blockers. We also use direct vasodilators. They have a minor role in the treatment of heart failure, but they will lower the blood pressure and relax blood vessels. We also use phosphodiesterase inhibitors, which block the enzyme phosphodiesterase, increase calcium for myocardial contraction, and cause positive inotropic response in vasodilation. This would be like Milnirone. Again, it blocks the enzyme phosphodiesterase in the cardiac and smooth muscle. With phosphodiesterase inhibitors, it's important to report irregular rapid heart rate, any sort of fever greater than 101. And drug therapy for heart failure, important to assess the patient knowledge. Your nursing diagnosis would be decreased cardiac output, excessive fluid volume, possibly deficit knowledge related to drug therapy, risk for reduced cardiac tissue perfusion. We have planning. You'd want to decrease the symptoms of the medication, report side effects, And of course, when you're implementing, you're monitoring for serum drug levels, signs and symptoms of toxicity, and monitoring the electrolyte, particularly potassium. And evaluate the effectiveness. The effectiveness would be decreased symptoms of congestive heart failure, weight returning closer to the dry weight. All right, the last little bit you have in this slide is an illustration of where these drugs work. And so you can see the vasodilators, how they work in the arterioles, the phosphodiesterase inhibitors, and the cardiac glycosides, where they work in the heart to increase the cardiac output. Our ACE inhibitors and our diuretics work in the kidneys.